All right, guys. Well, welcome back. As I said earlier in an email and things, I meant to do this yesterday, but things got in the way, and we just didn't have time. I hope you guys are getting used to the changes in the instruction and the delivery methods. I know it's kind of a stressful time for us all, and being able to have the technology to do this is great. So I hope that you are adapting to the changes, and if you have anything that you feel like is not being met or any suggestions that would make the experience better, please let me know, and we'll try and get those kind of rolling, okay? This is new for everybody, including me. So any constructive criticism is appreciated. So last time we talked about the pelvis and everything that we have going on with the pelvis, the three bones, the sacrum, and the two hip bones, as you will. We talked about how the sacrum is shaped with the tapered edges, and we talked about how the sacrum is kind of the keystone to the archway that is our hips, or our legs, really. Now we're going to move just a little bit more distal, just out to the hip joint itself, and we're going to talk about more muscles today. We're going to talk about not more ligaments, but the ligaments that attach to the hip. This chapter also kind of goes back and covers how some of the landmarks and some of the characteristics of the hip bones themselves. So the first probably 10, 15 slides are going to be a little bit redundant, and we're going to kind of cruise through those pretty quickly. So when in those slides, if all that sounds weird and confusing, refer back to last lecture, and it should kind of answer yourself. It's pretty straightforward. But yeah, and then we're going to talk, and then there's going to be a section of muscles. Again, we talked about muscles in lab, and so I'm going to briefly go through those, and I will probably just highlight some of the important things. Remember that you need to know origin, insertion, action, nerve with those muscles, and that even though I'm not talking about them, I'm not reading them off the slide because I think that you guys are able to read it yourself, that we still need to know it, but I am going to kind of hit some of the highlights as we go through, just so that we can make these 104 slides go just a little bit faster. Okay, I have my whiteboard handy. Again, like I pointed out in the last lecture, the pelvis lecture, I can't see the frame of where I'm at as I'm going through the presentation or the lecture. So if something that I draw isn't out there, let me know, and we'll explain it more during lab. Okay, but anyway, without further ado, here we go. Ooh. Come on, there we go. Okay, all right. So that's annoying. There we go. The lower extremity is made up of the pelvis with the two hip bones, the sacrum, the coccyx, the thigh, which is kind of comprises the femur, the patella, the leg, or the lower leg of the tibia and fibula, and our foot. Okay, everything we have for the foot. We are going to be talking about the thigh, and we're going to talk about a little bit about the hip bones, as it has a very important aspect. It's the proximal side of our hip joint with the acetabulum. Okay, but this is kind of our main thing right here is the thigh, femur, kind of patella. Okay, we're going to talk about one landmark on the tibia, just because it is involved with the two-joint muscle known as the quadriceps. Okay, so we're going to talk about one landmark on the tibia. The rest is going to be on the femur, patella, and on the ilium, ischium, and pubis. All right. So, yes, lower extremity. Here we go. All right. So, the hip, pardon me, is the most proximal of the lower extremity joints, important in weight-bearing and walking activities, obviously. As we discussed in lab, it's a ball and socket joint. So in an open kinetic chain, we have a convex structure, convexity of the femoral neck or the femoral head, articulating with the concave structure of the proximal end side of the joint, okay, the acetabulum. Okay? So with us going into any real direction, Remember our arthrokinematics, so we have a convex structure moving on a concave structure. The roll and glide are in opposite direction. Okay? It is way more stable than the shoulder joint, even though the shoulder joint is a ball and socket. Okay? This acetabulum is a lot deeper. Okay? So that acetabulum is a lot deeper, and the femoral head sits in it a lot more a lot further. Okay? With your glenoid fossa, right? Your glenoid fossa is like a dish almost with a little fibrocartilaginous ring. Okay, so with the shoulder, there's a lot of instability. That's one of the reasons why we've talked about we can move our arm in so many different motions. Okay, your hip is more stable because that acetabulum is a lot deeper. Okay, so what we gain for stability, we lose in the amount of motion. And you can probably feel that. If you were to stand up and you were to move your arm in all different kinds of ways, okay, and then you could try and move your hip in those same kinds of ways, you'd be a lot more limited with the amount of motion that you have in your hip. It's still a triaxial joint, okay? It still moves in the sagittal, frontal, and transverse planes, but it is a lot more stable. Therefore, it's not a lot, but it sacrifices mobility for that stability, okay? Which is good, right? Because we have weight bearing. We think of all the forces that travel up, all the ground reaction forces that travel up through your legs after you jump off of a plyometric box. Okay? Or you see these athletes who are jumping over things and flipping and kicking and all kinds of stuff, all the Ninja Warrior stuff. Okay? Think of all those forces that are traveling vertically up through those legs and now up into the spine. Okay? So having that very stable joint is very, very helpful and very, very protective of those things. And this is nothing new. Okay? We did mention that flexion is the same, abduction, adduction, lateral, medial rotation, these are all same. Remember that this text views coming from this position back down to neutral as extension, and anything past that as hyperextension. We will refer this as extension and this as flexion. Okay? So kind of coming down even past neutral and as far as you can go, we're just calling that extension because that's kind of standard operating procedure with the profession. Okay. So the hip, again, like I said, we're going to talk about this briefly. You have two hip bones connected anteriorly with your pubic symphysis and then posteriorly with your sacrum through your SI joint. Okay. The sacrum has a distal portion to it called the coccyx. Okay, or your tailbone. We talked about how painful having a broken tailbone is and how many things in your pelvic floor connect to that coccyx. So anytime that your pelvic floor contracts, if you have a fractured coccyx, you pretty much have a lot of issues, a lot of pain. Okay, we had those two hip bones, sacrum and the coccyx, equals our pelvic girdle. Again, we talked about that a lot. Okay, the pelvis obviously does not include the femur. So infield with the hip is going to be firm in all directions. Okay? This is due to capsular tension, and there's also some ligaments in there that we're going to talk about that also provide that tension. Okay? The one exception is in hip flexion, okay, because that is going to be a soft kind of tissue approximation is going to be the restriction for that. And when we start talking about the capsule, we start talking about the ligaments, you will see why it is soft for flexion. There's an anatomical reason for that. Okay? The open pack position is 30 degrees of flexion, 30 degrees of abduction, and slight external rotation. When Miss Jen was doing her hip mopes today, that is the exact position that she was putting her daughter in. Was 30 degrees of flexion, 30 degrees of abduction, and slight external rotation. Okay? Remember, open pack position is when there's maximum incongruency or maximal separation of the two joint surfaces. Right? Closed pack position is our dangerous position because that is where the joint surfaces and the ligaments are all as tight and as close as can be. Okay? So in that open pack position, there's room for error. Okay? You step in a hole and things shift in that open pack position, you're likely not going to have an injury. Okay? In that closed pack position, when things are tight, one little shift, you're going to tear a meniscus, you're going to tear a labrum, you're going to blow out your ACL, MCL, medial meniscus like I did when I was a junior in high school. Okay? Closed pack position is your dangerous position. Open pack position allows more flexibility. Okay? We talked about the arthrokinematics. So with abduction, you have an inferior glide. With flexion and internal rotation, it's a posterior glide. And extension and lateral rotation, it's an anterior glide. Okay? Do me a favor and draw an arrow out to the side and write, it is a posterior glide. Remember, early in the range, it's a posterior glide. And then once it gets above a certain position, that femoral head has to slide inferior. Okay, so for flexion only, you're going to have an inferior glide higher in the range. And this is just a good visualization of those arthrokinematics and how that roll and the glide, okay, the roll and the glide are going to be in opposite directions. All right. Pardon me. Hip bones. The hip bone, also known as the os causale. Nope. It's not os causale. It's os causae. Coxae. There it is. Okay. It's regular shaped. It has made up of the three bones fused in the middle. Okay. They fuse by adulthood, and where they fuse in the middle is exactly where the acetabular is. You will see in a minute. Femur, longest, strongest, heaviest bone in the body. Its height is roughly 4 times, or your height is roughly 4 times the length of your femur. Okay? There's reports of your femur requiring up to 2 tons of force to be broken. Okay, and that's a lot of force, especially for how many femurs that you see having been fractured. Okay? It articulates with the hip bones to form the hip joint. The reason for this lecture that we're doing right now. And right around here is going to be the acetabulum. The acetabulum, that proximal side of the hip joint, is going to be right where the 3 bones kind of fuse together. So anterior side, posterior side, remember this is the auricle that's going to articulate with the sacrum and form the SI joint. Okay. You have your ASIS, AIIS, ASIS, and AIIS. And you have your ischial tuberosity down here at the bottom. That's our sit bone. Okay. You have your pubic tubercle, and then this is where your pubic symphysis would be. Okay. And we're going to kind of go through this and hit these again just for the sake of completion. Okay. So on the ilium, and your ilium is that top bone, right? We have our iliac fossa, our iliac crest, our ASIS. Okay. We went through this last time. We also talked about it in lab. I don't believe I need to read through that. If you feel like I do, or if you have questions, again, please ask during lab or refer back to the last session, last lecture. Okay. We have our AIIS. We talked about the attachment site for the rectus femoris, and also we're going to get to it, the difference in the rectus femoris and the iliopsoas. Okay. On your ilium, you also have your PSIS and your PIIS. Okay. And those are the major landmarks of our ilium. In your ischium, you have the body, you have the ramus, and you have your ischial tuberosity. Okay, we talked about your ischial tuberosity being our weight bearing when we are sitting. And if you've ever sat on metal bleachers for a long time watching a sporting event or a concert or whatever, okay, you oftentimes will have to kind of shift around because that is not too comfortable sitting on a hard surface on your weight bearing ischial tuberosity. The ischial tuberosity is also a big attachment for our hamstrings and our adductor magnus. The spine is located on the posterior portion of the body between the greater and lesser sciatic notches and it's an attachment point for our ligaments. Okay, we switch the orientation of this picture on you, so if it looks different, there's a reason. Okay, so there's our ischial spine, our ischial body, tuberosity, and then our ischial ramus. Okay? And then this one has our acetabulum drawn in. Okay? And the ischium makes up roughly 2/5 of the entire acetabulum, so it's a pretty big deal. Okay? Your pubis, moving on to our pubis, there's the body. We have a superior ramus and an inferior ramus, and those are kind of come together to form the pubic symphysis. There's also the pubic tubercle, which is the attachment site for the inguinal ligament. We talked about that today and Monday in lab. And again, our pubic landmarks are outlined for you there. Okay. So the combination of our hip bones, our acetabulum, we talked about how deep it is. We talked about how it articulates with the femoral head and how it's made up of all 3 of our hip bones. Okay. The hip bone as well has our obturator foramen. That's our large opening surrounded by the bodies of the ramus and the ischium and pubis. Okay. Nerves and blood vessels pass through there. We have a greater sciatic notch, okay, which is where our sciatic nerve, our piriformis muscles, all pass through the greater sciatic notch. So there's our acetabulums. There's our greater sciatic notch, where our piriformis and our sciatic nerve pass through. There's our obturator foramen. It has our obturator membrane. And then the obturator canal is where those blood vessels and everything kind of pass through. All right, so that's kind of a quick little review, I guess, of the proximal hip bones. Now we're going to move into the femur. So the femur has the head that is a rounded portion covered with articular cartilage and articulates with the acetabulum, as we talked about. The neck is a narrower portion located between the head and the trochanters, right? So we've made comparisons to the glenohumeral joint with this because they're both ball and sockets. Okay? We can also compare the femur to the humerus. Okay? So the head of the femur, head of the humerus, both rounded, but the femur, as you will see in a minute, has a much longer neck than our humerus does. Okay? And that's going to come into play when we start talking about our angle of inclination and our angle of torsion. Okay? So that's going to be later, kind of towards the end of the lecture. Okay? But it has that longer neck, so it's going to be open to a little bit more discrepancies when we start talking about mechanics, where the surgical neck of the humerus is very short. Okay, so there's not a lot of change that can go on. Having that longer, narrower femoral neck can result in a little bit of discrepancies based on genetics and based on how those bones form during the formative years. And we have our greater trochanter, which is our large projection located laterally between the neck and the body. These are big attachment sites for our glutes, okay? And also our deep rotator muscles, those muscles that are deep underneath the gluteus maximus that allow that for our femur to rotate laterally. Okay? We have the lesser trochanter, which is smaller projection located medially and posteriorly, distal to the greater trochanter, and that is the attachment for the iliopsoas. Okay, so just like our humerus, we have a greater and lesser tubercle. On the femur, we have a greater trochanter and lesser trochanter. Okay, and they're roughly in the same positions. Okay. With the body, we have a long cylindrical portion between the two bone ends. That's the shaft of the femur. It can be bowed slightly anteriorly. We have the medial condyle, lateral epicondyle, and the medial epicondyle. Our condyles are going to be our articular surfaces. These are covered with articular cartilage. The articular hyaline cartilage is very smooth, very glassy, and when it's covered with the synovial fluid, it's almost a friction-free environment, bearing to mind that there's no discrepancies in that cartilage. So So you can feel this if you palpate your kneecaps and go medial and lateral. You can feel kind of how smooth they are. Okay? Our lateral epicondyle and medial epicondyle, those are going to be the projections that are going to be proximal to both the medial and lateral condyles themselves. We have an adductor tubercle, a linea aspera, and a pectineal line. Okay, that adductor tubercle is a small projection proximal to the medial epicondyle, and that's going to be the insertion point for our adductor magnus. The linea aspera is a prominent longitudinal ridge or crest that runs most of the posterior length, and our bicep, short head of our biceps is going to originate on the linea aspera. We have a pectineal line which runs from below the lesser trochanter diagonally toward the linea aspera, and this is where our adductor brevis is going to attach. And when we get to our adductor muscle group, you're going to see that there's they go by levels. Okay, your brevis and your pectineus are going to be those two most highest adductor muscles on the medial side of your thigh. And this is what we're talking about when we talk about the neck of the femur. You can see the differences between the humerus and the femur right here. Okay? Because here, if this was the humerus, the head would be right almost touching the greater tubercle, not trochanter. Okay? Both of them have the lesser trochanter, lesser tubercle, kind of roughly in the same position. On the humerus, it's up here a little bit though. Okay. So there's our adductor tubercle for our adductor magnus, and then our two condyles or articulating surfaces. Okay. On the tibia, like I said, we're going to talk about one landmark on the tibia. That would be our tibial tuberosity, and that is the attachment site for the patellar tendon, which is attached to the quadriceps muscle, the four muscles that make up the quadriceps muscle. Okay. It's a two-joint muscle, so it's going to cross the hip, it's going to cross the knee. Therefore, we're going to just briefly mention it. We'll talk about it later when we talk about the knee for sure. And there's our tibial tubercle right there. All right, so structures and ligaments. We have a joint capsule. Okay, that joint capsule is made of kind of the surrounding structure, but within that, we also have an iliofemoral ligament, a pubofemoral ligament, and an ischiofemoral ligament. Okay? And those three ligaments are going to have kind of a spiral attachment, a spiral kind of formation that's going to allow for kind of almost unlimited, not unlimited, but a greater amount of flexion and in tightness into extension. We also have the ligamentum teres, the acetabular labrum, and the iliotibial band and tract. And we'll talk about the importance of what that ligamentus teres holds within it and why it is important, especially when it comes to injuries and hip dislocations. But first, let's talk about that capsule. That capsule, like all capsules, maybe this one's a little bit bigger, stronger, more beefier. It's strong and thick. Okay, covers the hip joint cylindrically, approximately around the lip of the acetabulum and distally to the neck of the femur. Okay, so it's going to go around. It's going to be synonymous with the labrum, okay, of the acetabulum, and then it's going to go distally around the neck of the femur. When we start in 170 this summer, we're going to talk about hip fractures, okay, and why it's important and why hip fractures that occur proximal or within the hip joint capsule have a higher likelihood of healing versus the fractures that are outside the capsule and how they don't heal very well. Okay. It forms a cylindrical sleeve that encloses the joint in most of the femoral neck. So our iliofemoral ligament, there's three of them. Or no, this is one of the three ligaments that go from the hip bone out to the femoral neck. Okay. So it reinforces the capsule anteriorly. It's the most important hip joint ligament. It attaches proximally to the IIS and crosses the joint anteriorly, where it splits into two parts distally to attach to the intertrochanteric line of the femur. It's represented in an inverted Y, or it's often referred to as the Y ligament. Okay, this is anatomy. Okay, so we have lots of different terms for the same thing. So it's a iliofemoral ligament, it's a wide ligament, and it's also a ligament of Bigelow. Okay? And this limits hyperextension. So this iliofemoral ligament, okay, goes up to the AIIS and splits there and there. And you can start to see by these two pictures, okay, how it is like it's a spiral type of attachment. Okay? So these fibers now go down and attach kind of here. Okay? All right, let's move to the pubofemoral ligament. Pubofemoral ligament spans the hip joint medially and inferiorly. It attaches from the medial part of the acetabular rim and superior ramus of the pubis and runs down and back to attach on the neck of the femur. Okay? This one also limits hyperextension, but we're also throwing in abduction as well. Okay? So when we started talking about infields. We talked about how everything is firm except for flexion. Okay? These are two examples because these two motions, okay, are going to be limited by ligaments. Therefore, they're going to have a firm infield. Okay? Pubofemoral ligament on the inferior side, you can tell by that orientation of those fibers, okay, how it's going to limit hip abduction. All right, next we have our ischiofemoral ligament. Last of the three, covers the capsule posteriorly, where it attaches on the ischial portion of the acetabulum, crosses the joint in a lateral and superior direction, and attaches on the femoral neck. Okay. This one limits hyperextension and internal rotation. Okay. Our ischiofemoral ligament posteriorly, and you can also see that it has the same type of spiral orientation as the iliofemoral and the pubofemoral ligament. Okay? So imagine that we take this hip bone, okay, and we move it into your screen in an extension type of fashion. What's going to happen to all those ligaments? Are they going to get tighter or are they going to get looser? Okay? The answer is they are going to get tighter. Okay? Because of that spiral type of fashion to them. As you go into extension, those ligaments are going to get tighter and are going to limit the amount of extension that is available. And then as we go into flexion with that spiral orientation, okay, as we go into flexion, those ligaments are going to get put on slack. And they kind of unwind a little bit so that way you can have more flexion range of motion. And that is why when we talk about infields, that is why our infield for flexion is going to be a soft infield. Okay? Because it's not going to have the ligamentous restriction that the other motions are going to have. Okay? All three ligaments attach along the rim of the acetabulum across the hip joint in a spiral fashion. We talked about that. Talked about the spiral attachment, limiting hyperextension and allowing for full flexion. Okay. This is a good thing to do. So like standing with hips thrusted forward, it allows for stability in a patient with a spinal cord injury. Okay. If you have a patient who has a lower thoracic or a lumbar spinal cord injury, they will have the ability to stand and ambulate, not community ambulate, but household ambulate, because they can thrust their hips forward and kind of what we refer to as hang on their ligaments. Okay? So if I were to stand up, again, I can't see this in my screen, but if I were to stand up and thrust my hips forward, okay, I would be hanging on my ligaments. Okay, so if I didn't have any muscle innervation below the level of my belt, okay, and I thrust my hips forward, okay, I could theoretically hang out in this position. Okay? Because if I step back and you see it a little bit more, I'll thrust my hips forward. My line of gravity is going to go anterior to my knee. Okay, so that's going to keep my knee in full extension. I'm going to hang on my ligaments in my hips, and I will be able to stand erectly with assisted devices, but I could theoretically then ambulate in some form. Okay? It wouldn't be the prettiest thing that you would ever see, but it would be ambulation, which is cool. Okay. So, again, this line of gravity would be moved forward because our center of mass would move forward as well. So our ligamentum teres, this is a really kind of cool thing to talk about. It doesn't seem like it is, but when you start talking about kind of injuries, and especially athletic injuries, the ligamentum teres is always of concern. So you have this is a small intracapsular ligament, attaches proximally to the acetabulum and distal in the fovea of the femoral head. Okay? This is tight during adduction or external rotation when the hip is semi-flexed. And the cool thing about it is that it contains a blood vessel that supplies the head of the femur. So whenever you hear about an athlete dislocating their hip during play, or even your regular Joe Schmo who was in a front motor vehicle accident and dislocated their hip posteriorly, this is what the orthopedist is always concerned about. They're not concerned really about the bones. Okay? They're not concerned about the acetabulum. I mean, they are, but they can fix those. Okay? Those bones have a good blood supply. Okay? This is the main blood supply. This blood vessel is the main blood supply for the head of the femur. Okay? If that ligament is ruptured, guess what happens? Okay? The head of the femur loses its blood supply. Okay? When the head of the femur loses its blood supply, it then goes into AVN, or avascular necrosis. Okay? So we had a football player for Alabama, Tua, okay, the quarterback. He was awesome. He's going to lead the Crimson Tide to a national championship this year. Okay? I think it was third or fourth game of the season. He dislocated his hip and he blew out the posterior rim of his acetabulum. But again, the surgeon was not concerned about the posterior rim of the acetabulum. Okay? He was worried about the acetabulum. Okay? He was worried about the ligamentum teres. Okay? Because of that blood supply. Okay? He would have had a much shorter career if his femoral head would have lost his blood supply and went into avascular necrosis. Okay? I want to say, don't quote me on this, I want to say that Bo Jackson also had a ligamentum teres tear, and it resulted in AVN. Let me Google it. Hold on. I'm Googling something during a lecture on a video. This is not good. Okay. We're going to let that soak for a second. Yeah, so if you Google it, they start making comparisons between Tua's hip injury and Bo Jackson's. Okay? Because Bo Jackson dislocated his hip, okay, in 1991, and he tore that ligamentum teres, and he went into AVN of his hip, and he couldn't take the impact of a football game. Okay? So a little bit of sports history for you. There you go. Okay? The labrum, the acetabular labrum, just like the shoulder, it increases the depth of the acetabulum. Again, I believe that that's not really true of increasing the depth. I don't think that we should focus on that. I think what it does is it increases the congruency of the contact between the femoral head and the acetabulum and spreads out that force, like we talked about. Okay? Helps hold the head of the femur in the acetabulum, sure. Okay. But it also spreads out the force. Okay? Or it kind of locks it in a little bit. But there's our labrum, goes around the entire length of it. The inguinal ligament has no function at the hip joint. However, it does run from the ASIS to the pubic tubercle, and it's a landmark that separates the anterior abdominal wall from the thigh. Okay? There's an artery and vein that pass under it, and once they pass under it, they then become the femoral artery and vein. There's also the femoral nerve that passes under it as well. Okay? All right, moving on to the iliotibial band or tract. It's very long, very tendinous portion of the TFL muscle. Okay? Attaches to the anterior portion of the iliac crest and runs superficially down the lateral side of the thigh to attach on the proximal tibial or lateral tibial plateau. Okay, the gluteus maximus and TFL both have fibers attaching to it. In lab, we talked a lot about the role of the gluteus maximus in this. Okay, in this whole complexity, this whole complex here. At the end, we're going to talk about bursitis or greater trochanteric bursitis, and that's where the TFL goes directly over that greater tubercle, and there's a bursa in between. And when that bursa gets inflamed or irritated, okay, it starts to be painful. Okay, but in our profession, we're going to look at the cause of the cause. Okay, we're not going to inject it with cortisone like our primary care friends. Okay, we're going to look at the cause of the cause. The cause of the cause is that there's too much pressure on the IT band to provide that stability. So what are we going to need to do? We're going to need to strengthen the gluteus maximus to help take some of the pressure off of that TFL and not have so much pressure on the IT band. Goodness, on the IT band as it's running over the greater trochanter. And so you can see as it runs right over that greater trochanter, there's going to be a burst in there that can get irritated. Okay? If you wanted to, you could also draw fibers of the gluteus maximus that come from your sacrum and come and attach here. That's going to provide some stability or some force as well. Okay? So in feels soft or firm for everything except flexion due to those ligaments that we talked about a few slides ago. So our muscles, we have our iliopsoas muscle, our rectus femoris, sartorius, pectineus, adductor longus, brevis, magnus, our gracilis, gluteus maximus, deep rotators. And again, your deep rotators are your obturator internus, obturator externus, your piriformis, your gramelli, inferior and superior. Okay? Your book just kind of groups them all together. There is a table. I don't have my book on me. There is a table kind of towards the end of the chapter or when they talk about them that has all of them listed. Okay, and then we go into your hamstring group, your semimembranosus, semitendinosus, and your biceps femoris, and then your gluteus medius, gluteus minimus, TFL. Okay. So our muscles of the joint. Okay, if you like tables and you want to separate them, and it's helpful for you to separate them in your head of one joint versus two joint muscles, okay, we have that table here. So, iliopsoas, okay, it used to be psoas major and minor, or iliacus. You'll also see that on some anatomy texts that you will see. So you have your psoas major. This there's the iliacus, okay, but your book just calls the whole thing your iliopsoas. Okay. So it's going to attach onto your spine, anterior portion of your lumbar spine, and run all the way down to your lesser trochanter. Pretty cool muscle. If this muscle is tight, okay, what is going to happen to your lumbar spine? Are you going to have a flattening of your lumbar lordosis, or are you going to have an excessive curve of your lumbar lordosis? Okay? Again, when we talked about the spine and why when we talk about back pain, it's important to discuss or evaluate or assess what structures are being loaded and what structures are not being loaded. Okay? So if we have a tight psoas major, tight iliopsoas, okay, it's going to bring our spine in a normal standing position. Okay, it's going to bring our spine into an increased lordotic position. Okay, so when you sit, it's going to be able to be rounded. But as soon as that hip goes into extension or neutral, like when we're standing up straight, okay, it's going to pull that spine, that lumbar spine into more lumbar extension. Okay? People don't like to be in excessive lumbar extension. Your facets don't like to be loaded in extension. They are not a weight-bearing structure. Okay? So if you are having a patient that is struggling the patient with low back pain who is struggling with low back pain when they're standing, okay, we need to assess the stability or the status of our iliopsoas. Because if it's tight and not stretched out and not operating appropriately, it can cause some issues up in our low back. Our rectus femoris is another one of our hip flexors, and it's going to go from our AAIS, or our AIIS, sorry, all the way down to our tibial tuberosity. Okay? In lab, we talked about when each of these functions. Okay? So if we are in hip, I might as well just stay standing up. Okay? If we are in hip extension, like in terminal stance when I'm getting ready to move my left leg forward, okay, my iliopsoas is now maximally elongated. Okay? It's not going to be strong. Those actin and myosin fibers are not going to be overlapping enough to create a purposeful contraction. Okay? So when our hip is extended, it's going to be more our rectus femoris that's going to be stronger and be the more prime mover of our hip flexion. Okay? When we move into hip flexion, okay, now my rectus femoris is too short. So we have too much overlap of our actin and myosin. Okay? And now our iliopsoas is like, yeah, now this is my optimal length. Let me go ahead and kick in and provide the more strength and stability in that position. Okay? Let me know if we have any issues with that kind of concept. Okay? Sartorius, very long band muscle, goes all the way from our ASIS all the way down and makes up our first muscle that we've talked about of our pes anserine in our knee. Okay? If you want to talk about this, we'll talk, or not if you want to. We're going to talk about this with the knee. We talked about it in lab of the se grace before T. The S is the se in se grace before T. Okay? You can also write above this your Captain Morgan muscle because it's going to bring your knee up and out. Your pectineus is your highest, your most proximal hip adductor muscle. This is the muscle that when you hear someone have a groin strain, this is going to be the muscle that they strain, is your pectineus. Okay? When someone says, I have a groin strain, they usually grab kind of right in here. If you've never skateboarded and had your skateboard kind of go out from you, or if you've never been water skiing and have one of your water skis go out, or however else you get a groin injury. Not that I know from experience, okay? But the pectineus is going to be high, and it's going to be that groin strain injury. Okay, so I don't know why they don't call it a pectineus strain. For some reason, we want to call this a groin strain, but it is really the pectineus. Okay. Your adductor longus is going to, I don't like how this does this. We're going to go in my order. Okay, so next, kind of going from lowest to highest, we had our gracilis. Wait, we didn't even talk about the gracilis yet. Okay, so we're going to do it in a little bit different order. Okay, so our gracilis is a two-joint muscle. It's going to cross the hip joint, and it's also going to be our G in our se grace before T for our pes anserine. Okay, so it's going to have that same insertion as our semitendon, or as our sartorius. Semitendinosus as well. Okay, but we'll get to that. Okay, hip adductor. Okay. Next, moving on up, is going to be our adductor magnus, and you can see this portion over here as it connects or as it inserts onto the adductor tubercle. Okay. And that also does, it's a very big muscle. It also connects on the entire linea aspera. Okay. And then moving up closer and closer, we have our adductor longus that's going to insert on the middle third of the linea aspera. Oop. And our adductor brevis, that's going to insert on the pectineal line in proximal linea aspera. And then you're going to have your pectineus up here as well. Okay. All these muscles create our hip adductor group. Okay. Our bodies were designed very much to not allow us to do the splits. All right, so moving into our gluteus maximus or hip extension group. Okay, this is going to be our big move, our big posterior chain muscle that's going to provide us with a lot of different activities. Traditionally, the gluteus maximus is just traditionally thought to just provide extension. Okay? But the outlier is going to be hip external rotation. Okay? You can also add in here hip abduction or hip stability through the use of the IT band. Don't forget that it inserts onto the IT band. That's very important and is often overlooked. Okay? So in lecture, we talked about how when we load our lower extremities, everything wants to crash in. Okay? You go into hip adduction and internal rotation. Okay? Especially if we have someone with patellofemoral pain syndrome, where that kneecap, and we'll talk about this a lot. I'm prefacing this a lot, foreshadowing a lot with the knee. Right? But when we go into knee valgus, everything crashes in, our femurs internally rotate. And that's going to cause tracking issues with our patella. Okay? If the gluteus maximus isn't strong, okay, it needs to be strong to help pull those femurs out. Okay? Externally rotate those femurs and to provide that stability. Okay. All right. And I don't want to talk about that too much because we're going to talk about the knee and we're really going to lay into it. We'll also talk about it a lot. We'll talk about those mechanics a lot in 140 when we get there. Okay. Your external rotators, again, we have our obturators, we have our piriformis, we have our gemelli, and our quadratus femoris. We have all kinds of little tiny muscles that help stabilize the posterior side of our hip. Okay. And so in lab, we pose the question, okay, we have all these muscles that provide hip external rotation. We have our deep external rotators. We have our glute, right? The one muscle that we have to provide internal rotation, okay, is going to be a side thigh. Okay, it's not a strong. We don't have a muscle whose sole responsibility is hip internal rotation. Okay, it's going to be the job of the gluteus minimus, and we'll get there. Still in the hip extension group, okay? Semimembranosus and semitendinosus. Both of them have the same origin of the ischial tuberosity. Okay? The difference is going to be in the insertion. Okay? So our semimembranosus lies deeper to the semitendinosus, and it has a more proximal insertion site. The semitendinosus lies on top, and it has a more distal insertion site. Both of them are two joint muscles that are going to provide a hip extension and also knee flexion, depending on what else is stabilized. Okay. Our biceps femoris has two heads. It has our long head and our short head. Our bicep long head goes from the ischial tuberosity all the way down to the fibular head. Whoop, there. All the way down to the fibular head. Okay? They have the same insertion, but the origin is different. Okay? The bicep, short head of your bicep, has a origin on the lateral lip of the linea aspera, so midline of the femur. So semitendinosus and semimembranosus have different insertions. Biceps femoris have different origins. Then we have our two adductor group, so our gluteus medius and our gluteus minimus. 3 in the adductor group if you include the TFL. Okay. Gluteus medius and gluteus minimus help to provide that lateral stability. If our glutes are weak, if our glute max, glute min, and glute med are all weak, okay, our body's going to rely on our tensor fascia lata in the IT band to provide that stability. What happens when our body relies on that for stability? We start to get greater trochanteric bursitis. Okay? So treatment for that is going to be increasing the strength of our butt and increasing the strength of our two lateral gluteus medius and gluteus minimus. Okay? Population that gets trochanteric bursitis the most, older adult females. Okay? Do they like to get stronger? Usually not. Usually these are the patients that you're going to come in, you're going to strengthen, you're going to target those muscles. They're going to come in the next time and say, oh, I'm so sore. And you're going to be happy. You're going to be high-fiving yourself, patting yourself on the back, have a big old grin, and they're going to look at you and call you the devil. It's happened. Call me the devil all the time. But it's a good thing. Okay. All right. Tensor fasciae lata is going to be more anterior to the 3. Most anterior to the 3. In order to really isolate that, you're going to bring your leg into, or your hip into flexion and kick out into abduction. And we're going to be concentrating on the TFL. Okay. That was longer than I wanted, but we highlighted the main highlights. Okay. Reversal of muscle action. Remember, the reversal of muscle action is when it is no longer an open kinetic chain. It is now a closed kinetic chain. And now the insertion, or the origin, is moving towards the insertion instead of the other way around. Okay. With your gluteus medius and minimus is going to be standing on one leg, and that's going to be how we control our pelvic tilt during closed kinetic chain. If it didn't contract with single leg stance, the opposite side of your pelvis would drop, and we call that the Trendelenburg gait. If I'm walking, and we did this in lab, so I'm gonna redo it and see what happens. Okay? So if your gluteus medius and minimus are weak, when you stand on one leg, you're gonna get what we call hip drop. And if we do that repeated during our stance phase of our gait, you get the kind of the sachet type walk, where that contralateral during stance, that contralateral side of the hip drops, foot, drops, foot, drops, foot. Okay? Trendelenburg gait. Again, we'll talk about that more when we talk about the gait mechanics and whatnot. That's just if those are weak, you're going to get the drop during our stance. There's our anatomical relations. I'm just going to breeze through this. I don't think that we need to really concentrate on that too much. Okay. All right, so moving into common hip pathologies. Okay, we have a congenital hip dislocation, our leg calf Perthes disease, our slipped capital femoral epiphysis, our angle of inclination, coxa valga, coxa vera, angle of torsion. Okay. Really, you could take your coxa valga and coxa vera and kind of push them over, because those are part of your angle of inclination. Okay. Same thing with your angle of torsion and anteversion and retroversion. We also have OA, hip fractures, iliotibial band syndrome, trochanteric bursitis, hamstring strain, and a hip pointer that we will also talk about. We're going to talk about more kind of pathologies, orthopedic pathologies in 170 when we talk about our orthopedic pathologies. So congenital hip dislocation, also known as dysplasia, usually due to a shallow acetabulum. Okay? If that acetabulum is shallow, that femoral head is just going to slide upward. If you've had kids, okay, when that pediatrician comes in after birth, this is part of their evaluation. They're going to take your infant's legs, okay, and they're going to move them up one at a time, and they're going to move them up at the same time, okay, because they're testing for hip dysplasia. Okay? The earlier we can catch it and the earlier we can be aware of it, the better outcomes that we can have. Okay? The joint capsule remains intact, okay? And hopefully we don't have a loss of blood flow. Okay? That is referred to as leg calf Perthes disease. Okay? Coxa plana is due because the head of the femur now is created, okay, and it's kind of like a flattened surface, where the femoral head undergoes avascular necrosis. Okay? It's not, I don't know if the etiology is well understood, right? But it's seen in children between the ages of 5 and 10, and it can take 2 to 4 years for the head of the femur to die. Okay? It's going to revascularize and then remodel. Okay? If you or I, because we're into skeletal maturity, if we have AVN of our femoral head, it just dies, and we have to have a replacement eventually. Okay? In the kids, it takes about 2 to 4 years for the tissue to die. It will revascularize and then remodel. So when it remodels, okay, it's going to be flatter. And what happens is the activity level for these kiddos is going to be severely restricted until they reach skeletal maturity and they can throw in a hip replacement. Okay? So activities for these guys during adolescence is really challenging. There's a lot of mental aspects of this that kids need kind of therapies and consultation for, because it's something that debilitates their movement and makes them different, and that's usually very traumatizing. Okay? But swimming, bicycling, anything that is low impact, they are free to do and they're encouraged to do. Slip capital femoral epiphysis is seen in children during the growth spurt years, okay, where the proximal epiphysis slips from its normal position on the femoral head. This is usually due to a high impact or a trauma, like jumping from a high height. Okay, this is one of the reasons why trampoline parks are so scary for people like us. Okay, or like my wife, who's in pediatrics. Okay, when we see trampoline parks, we usually kind of cringe a little bit, okay? Because you have kids who have not reached skeletal maturity doing repeated high-impact trauma, okay? What can be the result? This can be the result, okay? And when that epiphysis slips off, guess what you now do? You now stunt the growth of that long bone, or you have the possibility of stunting the growth of a long bone. Okay? So I don't want to say trampoline parks are bad. I would love to go to a trampoline park, but I'm very hesitant to allow my kids to go to one. Okay? For this sole reason right here, the slip capital epiphysis. All right, moving into the angle of inclination. This is the angle between the shaft and the neck of the femur in the frontal plane. Normally it's about 125 degrees. Okay? At birth, it's a little bit more with a max of 170 degrees. By adulthood, as kids go through puberty and into skeletal maturity, that angle decreases to the normal amount. Okay? Congenital deformity trauma or disease may affect that angle. Okay? So normally it looks like this. Now, I will say that I like to think of it as the femoral head and the femoral neck will always come out of the acetabulum at this line. Okay? So when we have coxa valga, okay, you can see how that's coming out relatively similar to that. So you're going to have, you see that that femur is kind of at a different position. We can't really see it because we don't know what the orientation of the pelvis is. Okay? But if I draw my pelvis on my whiteboard, again, I like to draw my pelvises as a triangle. Okay? And you have your two femoral necks coming out at roughly the same angle. Okay? If I have coxa valga, my femur is going to come out to the side. Okay? And if I have my knee, then my knee is going to come in. And this may be kind of, you can think of this as people, as where is my horse? Is that what Jen says? I don't know. Jen will have to talk about it. Okay? So that's going to come out more. Okay? So the angle is straighter, so the limb is longer, putting the hip in adduction in an adducted position during weight bearing. Coxa vara is characterized by a neck shaft angle less than 125 degrees. Okay? Right there. Okay? That is going to result in that knee, that femur coming in. Okay? If we have that, it's going to go out to the side. Okay? Angle is more bent involved. Limb is shorter, dropping the pelvis on that side during weight bearing. Okay? So, coxa valgus, longer limb. Coxa varus is going to be a shorter limb. Okay? Hopefully that makes sense. Okay? That's not just a fun guy dancing, as it kind of looks like. And then moving into the angle of torsion, okay? This is anteverted and retroverted. Okay? Normal, where that femoral neck inserts onto the femoral shaft, is going to be roughly 15 to 25 degrees. Okay? If it's greater, is going to be an anteverted. Okay? Where that neck, I like to think about it as that femoral neck is inserting onto the shaft anteriorly, more anterior, so the angle is higher. Okay? I really like this drawing because it puts those two dots where that femoral head is going to come out of the acetabulum, usually. Okay? And then when that is, you're going to have a relative hip internal rotation, or it's going to, I guess it would be kind of a pseudo internal rotation, because that hip's not in internal rotation, but it's going to appear like the hip is in internal rotation because you have a toeing in. Okay? If you start, you're going to, especially once we start going into gait, okay, you're going to start looking at everybody that you pass by and how their feet are hitting and how they're walking. Okay? If they're pigeon-toed and they walk with their toes in, okay, it's a very high likelihood that they have anteversion. Okay? It's all going to come from the hip. It's not going to be really from the knee. It's mostly going to come from the hip. Okay? The contrary, the exact opposite of that, is retroversion, where that femoral neck inserts posteriorly on the femoral shaft. We have a decrease in that angle of torsion. Okay? Where we have a relative hip external rotation, or a pseudo hip external rotation moment with this. Okay? These are our out-toers. These are people that you see walking down the street and they're pushing off the medial side of their feet. Okay? Again, it's not coming from their hip. It's usually not coming from their ankles. It's usually going to come from their hip. Okay? I meant the knee. I meant to say the knee before. It's coming from the hip, not the knee or the ankle. Okay? And over time, it can be severely diminishing that the arch, especially if you're not wearing good footwear that supports your arch. Okay? If that arch isn't supported and you're constantly pushing off of your arch on the medial side of the foot, it's eventually going to flatten that arch and that navicular is going to be hitting the ground. Okay? And this is just this is normal, anteverted, and you can see how the femoral condyles, the patella, are all internally rotated. Retroversion, where the condyles, okay, and the patella are going to be toed out, or externally rotated, or pseudo-externally rotated. Osteoarthritis is a degeneration of the articular cartilage of the joint. You'll also hear this called degenerative joint disease. Again, you already know my stance on the disease portion of it. Just call it what it is. It's osteoarthritis. It's degeneration. It happens to everybody, just at different rates. Okay? Results from trauma or wear and tear. You can write over here completely normal. You can write normal over here. Obviously, it's going to be typically seen later in life because that's when we start wearing thin on the tread of the tire. Okay? Commonly treated with a total hip replacement. This is a very common surgery. It's going to happen a lot. We're going to talk about this more in 140 and then again in 170 over the summer. Okay. In the picture on the left is in the x-ray. You can see the normal joint space. Over on the right, you can see the diminished joint space because there's no articular cartilage left. Okay. Especially in this area. There is no joint space left. There's no cartilage left, and that's why we have bone on bone. Bone on bone. Hate that. Cliches. I hate cliches. Right? And then you also have some degeneration with some bone spurs around there as well. And this is a total joint replacement, total hip replacement with the stem that goes down into the intermedullary canal. And it is usually a kind of a porous coating, so it's going to kind of fuse with the bone in there. And then there's a femoral component. There's also a replacement of the acetabulum with the like a polycarbonate spacer in there for a friction-free joint. Okay. Hip fractures, intertrochanteric fractures, femoral neck fractures. These are common among the elderly, and they usually result from falls or high-impact NVAs in the younger individuals. If you have a young person, like less than 50 years old, with a hip fracture, it's usually going to be from a trauma or from a pathology. It's not going to be from a fall. Okay? Normal, healthy young people don't get fractures when they fall. And again, we're going to talk about the different types during, I think, 140, if not 170. You can see the fracture line in there. And that's usually what you get. Usually get some screws put in, and it's usually very painful, especially if you have one of my least favorite types of patients to treat in the acute care setting is your elderly individual with dementia who has a hip fracture. Fell at the nursing home, fractured their hip, came into the hospital, got some screws put in, and they are in pain, and they don't know why, and they are just the most difficult patients to treat. Okay. All right. IT band syndrome is an overuse injury. Lateral knee pain seen in runners and bicyclists is due to the repeated friction of the band that slides over the lateral femoral epicondyle during knee motion. Okay. This can also be called snapping hip or snapping knee syndrome. Okay. Causes muscle tightness, worn down shoes, running on uneven surfaces. You could also say muscle weakness. Okay, if I am a runner or a bicyclist and that's all I do, okay, think about what plane those two activities are in. Okay, you have an answer in your head? Okay, those two activities are strictly within the sagittal plane. Okay? Guess what muscles aren't being utilized in the sagittal plane? If you guessed your gluteus minimus and gluteus medius, you would be correct. Okay? Yes, they are stabilizing the hip during single leg stance. However, those muscles need to be strong. Okay? Because without strong hip abductors, okay, your body relies on this IT band to stabilize that hip abduction moment. Okay? And when this is overutilized, it starts getting painful and irritated and angry. Okay? Down through here. And actually, it can be this whole thing. So what have you seen of people doing to treat this? Okay? If you have heard anything about the mainstream media, they say that you need to roll your hip, that's going to break away the adhesions. Sorry, my treatment biases are coming out. Okay, it's late. Okay, you're going to have to roll the hip, and that's going to stretch the IT band out. That's going to release adhesion, and it's an all-saving grace. No, you're lying. It's not going to happen. Okay, this IT band is thick. It's 2 millimeters thick. It's 5 centimeters wide. you're not going to stretch those collagen fibers out by rolling on it. Okay? What you are doing, you are kind of overstimulating the nerve endings, so that they stop firing. You are doing that. Okay? But if you want to make a lasting impact on IT band syndrome, guess what you have to do? You have to come up in here, and you have to do the work, and you have to get these 3 muscles stronger. You have to get your glutes stronger, you have to get your gluteus medius stronger, you have to get your gluteus minimus stronger. Okay? Those 3 muscles are going to be able to take the force off of that IT band and help with that lateral stability of the hip. Okay? You've probably heard of the importance, especially for our runners and our bicyclists, of the importance of cross training. This is why. This is one of the reasons why. If this is all you do, you are not strengthening and providing enough stimulation to provide a sufficient strength for these muscles, and you're going to end up with an IT band syndrome. Okay? Moving kind of those same principles, moving into trochanteric bursitis, except we see it in a different patient population usually. Okay? Results of either acute trauma or overuse, seen in runners or bicyclists as well. Also, I feel like when I was in practice, I usually saw my older women who went out and tried to go shopping for 6 hours straight and ended up with some trochanteric bursitis. We can also see it with someone with a leg length discrepancy, because that longer limb is going to take more of the brunt of the force than your shorter one. Okay? Or if you sleep on a really hard surface. Like sometimes when you go hiking and you sleep on the ground. Okay? Anybody gone on an overnight hike? Hopefully you brought a sleeping pad with you, or you slept on a pile of leaves, or you slept on your back. Because if you sleep on your side, you may get up in the morning with some trochanteric bursitis. Okay? Treatment for this, same thing. When you need to release the pressure of that on that bursa with the IT band. Okay? We need to release that pressure, and we do that by getting the glutes stronger. Usually it's always going to come back to strengthening. Then our pulled hamstring, or hamstring strain, most common muscle problem in the body, especially with athletics. Okay? Once you have one really bad one, you are more prone to the others, to having more. It happens from an overloaded muscle trying to move the muscle too fast. Common among sprinters, soccer players, track and field, football, rugby. Okay? Usually it's going to occur at the musculotendinous junction. Okay? So right where that muscle kind of comes, especially our hamstrings, right where that hamstring comes off of the ischial tuberosity is where you're going to see it. And a tall tale time is sprinters and football players who are running, and all of a sudden they grab for their butt and they pull up. Okay? You can almost 100% of the time bet that that's going to be a hamstring strain. Okay? They're going to do this. They're going to grab the back of their leg, they're going to grab up at their butt, and they're going to cry. Not cry. That's insensitive. They're going to have that face. And there's going to be a lot of bruising. A lot of bruising. A whole heck of a lot of bruising. Okay? A great instance for our open lantern of our K-tape or our rock tape. We'll talk about those taping techniques for bruising and edema in 160 next fall. Okay? I'm not giving away all of our secrets just yet. Okay? And our hip pointer occurs at the pelvis, where there's a severe bruise caused by direct trauma to the iliac crest of the pelvis. See it a lot in football, where a helmet comes in and hits right at the hip. Okay? That's what it's going to look like. You're going to get a nice bruise. Okay? They're going to limp for a little bit because the muscles that are underneath there, your gluteus, your TFL, gluteus minimus, gluteus medius, are all going to be in a little bit of sad shape there for a little bit. Okay? The next couple pages are slides are prime hip movers. You also have your hip muscle innervations. and our points to remember. So read through those. I hope that you have learned a whole heck of a lot. We went an hour and 14 minutes. Okay? And as always, if you have anything, if you have any questions, be sure to write them down. Ask them during lab, and we'll get things situated. Okay? Hope you enjoyed my voice and kind of us talking about things. I'll see y'all next time.